Recording in progress.
This is the moment for political action. This is the moment for universal health coverage. This is the moment for caring. Join the movement online. Share your caring moment on Instagram or TikTok. It's simple. Create a post, reel, or story. Use one of our filters and share using hashtag NCD Caring Voices. Want to get more creative? Add one of our stickers, easily searchable within Instagram or TikTok. Your post is then picked up by our team and shared on our website. The moment for caring is now.
Good evening, everyone. Hope you all had a very productive day and looking forward to having a productive session today. On behalf of NCD Alliance and the Leona M and Harry B. Helmsley Charitable Trust, a very warm welcome to each and every one of you. Today's event, Invest in and Engage People Living with Non-Communicable Diseases, Next Steps to Realize Universal Health Coverage, is all about bringing everyone together and speaking in a unified voice. My name is Monica Arora. I am president of NCD Alliance. I'm from India, and back home, I am executive director of an NGO working on NCD prevention and control with youth, that is Hriday, and I am vice president research at the Public Health Foundation of India. In the last few months, I have also had the honor of representing the UHC 2030 Coalition of Partnerships for UHC and Global Health, on a task force to craft the 2023 action agenda from the UHC movement. We meet in person here in Geneva on the sidelines of the 76th session of the World Health Assembly, but we represent individuals, countries, organizations from all across the globe. We meet here to talk about non-communicable diseases, that is, heart diseases, cancers, chronic lung diseases, diabetes, mental health, neurological disorders, which are all the world's #1 killers. We meet to talk about universal health coverage, the noble goal, as we all know, of ensuring that everyone has access to quality essential health services, regardless of their ability to pay by 2030. So this is a very timely meeting, and why I say so, it's because UHC has been described as the single most powerful concept that the public health has to offer and a key instrument to enhancing sustainable human development. In 2019, world leaders committed to this goal through the first UN high-level meeting on UHC. Now, mistakenly, UHC is understood by many as just investment into covering the healthcare cost, but it is more. UHC is for service coverage, it is for population coverage, it is for financial coverage. But we need not forget that if there is no access to NCD services, if half of the adults living with diabetes are undiagnosed, then we are unable to get universal health coverage. Similarly, when we say UHC is for population coverage, yet people in the marginalized communities have a higher risk of dying from NCDs than the general population, then how UHC can be achieved so long as we accept that 85% of the premature deaths from NCDs occur in low and middle income countries. And financial coverage, yes, globally financing for NCD has been stagnant over the last 30 years, leaving people living with NCDs feeling the financial burden. How can UHC be achieved unless we break the cycle of generational poverty caused by NCDs? So while we have been making progress on UHC in the past 4 years, the Director General's report on UHC to the WHO this week notes that the rate of progress actually has slowed since 2015, with financial coverage actually regressing from 2000 to 2019. The 2022 State of UHC report published by the UHC 2030 identified 3 reasons: inadequate financing, lack of concrete operational plans, or formal accountability mechanisms that had pushed this progress off track. So the upcoming second UN high-level meeting, which is planned for September 2023, which will be back-to-back with the 2 other HLMs, which is pandemic preparedness and tuberculosis, is a crucial opportunity to address these challenges head-on. So today's event, we will hear esteemed honorable colleagues discussing on these issues. And why today? Because today the zero draft of the political declaration for the September UN high-level meeting and UHC is released. So we will be talking about investing in accelerating implementation of NCD prevention and care in national UHC health benefit packages as fundamental to achieving health for all, and engaging people living with NCDs is vital to keep UHC people-centered, locally relevant, appropriate, and sustainable. So we all have a role to play, but it is government's role to lead. We meet today to ask for your leadership and action for people living with and at risk of NCD in your countries. With this, I would now like to invite Dr. Jerome Salomon, Assistant Director General, Universal Health Coverage, Communicable and Non-Communicable Diseases at the World Health Organization, to share his thoughts on the topic.
Excellencies, ladies and gentlemen, dear colleagues and friends, Mrs. President, dear Professor Monica Arora, I strongly believe that each one of us gathered here today shares a collective mission to ensure that every individual, regardless of their identity, location, or health conditions, is equipped with everything they need to achieve the highest standard of health and lead fulfilling lives. However, we must acknowledge that achieving this goal is impossible without placing the voices and expertise of individuals who have lived experience with health conditions at the very heart of the decision-making processes that directly impact their lives. Their invaluable insights, perspectives, and personal journeys provide us with a profound understanding of the challenges they face and the solutions that will truly make a difference to move forward towards universal health coverage. By actively involving those with a lived experience, we can gain a comprehensive understanding of the intricate realities they encounter on a daily basis. Their first-hand knowledge equips us with the ability to develop policies, programs, and interventions that are truly responsive, effective, and tailored to their specific needs. In the past 2 years, the World Health Organization has embarked on a series of initiatives to promote and advance the meaningful engagement agenda. These endeavors have been led by the Global NCD Platform, the Mental Health and Substance Use Department, and the NCD Department. One example is the campaigns aimed at amplifying the lived experience of individuals affected by cancer. Another example relates to diabetes. In 2022, member states launched the Global NCD Compact 2020-2030, which aims to ensure that member states adopt policies and programs to improve outcomes related to non-communicable diseases and save the lives of individuals living with NCDs. One of its 5 commitments is to meaningfully engage by 2030 1.7 billion people living with NCDs and mental health conditions, to encourage governments to develop more ambitious national NCD responses and to contribute to their implementation. Last, I would like to acknowledge the importance of the recently launched WHO framework on meaningful engagement. This framework emphasizes that participation should be inclusive and accessible, particularly for marginalized perspectives and identities. It recognizes meaningful engagement as a rights-based approach to addressing health inequities and working towards achieving health for all. We eagerly anticipate hearing from countries, the private sector, and civil society about their active engagement with people living with non-communicable diseases. It is of significant importance to understand how this engagement is contributing to the progress towards achieving universal health coverage. By learning from one another and adopting best practices, we can accelerate the path towards equitable and inclusive health systems. Thank you very much.
We would now like to invite Dr. Robert Yates to moderate today's proceedings.
Many thanks, Monica. Greetings. My name is Robert Yates. I'm the Executive Director of the Centre for Universal Health at Chatham House in London. We specialise in the politics, the political economy of health and health reforms. And I'm really hoping that today's very frank and honest discussion is going to embrace the politics of access to NCD services, because really when you think about UHC reforms, who gets what, who pays for what, who gets the benefits, these things are really more political than they are technical on the many occasions. So I think this is an opportunity for this fantastic group here to really discuss tactics that we might employ to make sure that we extend NCD coverage, looking at the big meetings coming up later this year at the UN. So the purpose of today's session really, I think, is to look at sort of three things really. First of all, where are we at the moment? Almost like a situation analysis in terms of integrating NCD services into UHC reforms. Then be thinking, what are our sort of best lines? If we're going to try and persuade ministries of finance and heads of state about the benefits of NCD coverage, what are the economic and developmental benefits that we can be promoting? And most importantly, I think, to bring people along with us, you know, how do we engage youth groups, civil society organizations, politicians, the media to get what we want? So that's the purpose of today's discussions. And we're going to have two panels that we're going to fit in the next hour or so. So it's going to be quite rapid stuff. And you know, we're hoping for nice, lively discussions. And I do please ask my panelists to be succinct because I genuinely do want to sort of try and bring in some audience participation as well. So hopefully each panel will have, you'll have some opportunity to grill the panel about their thoughts. So if I can invite up my first group of panelists who are going to be looking at these issues of where are we now and, you know, the investment case, I suppose, really for NCD coverage. And the panelists for the first panel are Dr. Tamar Gabunia, who is the first Deputy Minister of the Ministry of Internally Displaced Persons from the Occupied Territories, Labour, Health and Social Affairs of Georgia. So that's obviously quite an extensive brief you've got there, Doctor. We have Dr. Bente Mikkelsen, who is the Director of the NCD Department of the World Health Organization. Professor Stephen Jan, who is the head of Health Economics and Process Evaluation Program, the George Institute of Global Health for Global Health. And finally, thank you very much, Ms. Rishika Singhal, who's the president of Medtronic Labs. Yes, that's fantastic. So I'll come and join you now. And what we're going to do to save a little bit of time, you've each got a microphone here. We've got a couple of questions, and I'd like to run the questions together, please. So you can sort of combine your answers, as it were, and I think that gives you about 4 or 5 minutes to address the questions I'd like to pose to you. And first of all, if I may turn to you, Minister Gabunia, looking at the situation in Georgia, how important would you say it has been to invest in NCDs in Georgia, thinking about progress towards universal health coverage? And maybe you're sort of reflecting on your experiences through COVID-19. And looking forward, what do you think are the opportunities at the high-level meeting coming up to really advance the cause of NCDs?
Thank you very much for this opportunity. It's my pleasure to be here and to share Georgia's experience. Georgia launched the so-called Universal Healthcare Program back in 2013. And since then, substantial investment has been made in healthcare and strengthening health systems, as well as increasing the budget to meet major needs of the population. Of course, NCDs are among top priorities, and we all know how important it is to have well-functional preventive programs at primary care level and have NCDs detected as soon as possible, and then provide adequate care and continuous support, as well as provide rehabilitation services for those who need them. That, for instance, for people in post-stroke period, to minimize devastating impact of this condition. Georgia, along with UHC program, has expanded access to chronic disease management drugs, which was a big movement, because in 2013 we had almost $0 paid for drugs, but these days we have around 40 million Georgian currency allocated to a chronic disease drug management program. And it's very important because UHC means providing access, timely access to high quality services and quality pharmaceuticals. And we all realize that without providing a means for people to manage their conditions, all efforts are useless. That's why we are trying to employ a comprehensive approach to managing NCDs and to have our primary care providers very actively working with their communities on behavioral change, as well as on convincing them that it's important to comply with treatment regimens and to take drugs. Of course, all these policies are quite complex to implement. Despite the financial support, we are still working very hard to improve capacity of primary care providers, and it's obvious, and without having a well-functional PHC system, it's very difficult to address NCD-related burden. And these days, we've been working very hard with the government and all partners to have effective policies to improve capacity of primary health care, as well as to expand access to chronic disease management drugs. We work with professional societies to introduce clinical care pathways for selected conditions. We call that outpatient care sensitive conditions that can be effectively managed at outpatient level without using expensive hospital services. In addition to investment in bringing together all healthcare providers and strengthening health systems, it's very important to invest in public health services because NCDs as a public health concern require very robust interventions at the public health level, including legal framework for addressing major risk factors, including tobacco control, as well as having good, well-developed information campaigns to contribute to behavioral change. And it's very recent that Georgia started to work on salt reduction strategies. And our government recently endorsed a new strategy for NCDs, which was largely informed by investment case that was developed with support from the World Health Organization and international partners. Having economic evidence helps a lot to convince policymakers to mobilize additional resources, and this is how it worked. And we hope that more resources will be mobilized to support NCD programs in the future. So joint efforts is very critical. We have good experience in relation to tuberculosis, HIV, Hep C, how important it is to have civil society partners closely engaged in disease management programs. It's never happened to that extent for NCDs, but it's very important now to take momentum where now we have this windows opportunity open with a new strategy, and to bring more players and to again have joint efforts towards reducing NCD burden. I would stop here and I will take questions if any. Thank you very much.
Thank you very much for being admirably concise there. And I think very important as well, you're emphasizing access to medicines being absolutely sort of crucial in this. And I think in many respects, access to NCD medicines is the front line in UHC reforms in so many countries where you see very high out-of-pocket expenditure, thinking particularly in South Asia, and this being the big issue, that it is sort of crippling families and throwing them into poverty. So I think really sort of commend your government for really giving that such a high priority. Now, if we can hear from WHO again, please, Dr. Mickelson, and what would you say are sort of the roles of sort of governments and civil society in really sort of forwarding the cause of NCD prevention, looking at the UHC 2030 agenda, and where do you see the opportunities coming up, sort of maybe with high-level meetings to really sort of push this agenda?
Thank you very much. And I think the discussion about integration needs to be clarified. I think I'm in too many meetings where the discussion ends up with, yes, we have to integrate. And we have to ask ourselves, what is integration? So when we talk about integration into UHC, what we really talk about is to identify the opportunity cost in the country and give the priority to NCD, which now accounts for 74% of all deaths, but of course, even more when we move into morbidity. So for me, it's really about first and foremost to give priority. And I think all hands needs to be on deck, and civil society is extremely important. I think what we have seen now from mobilizing and inviting in people with lived experience together with civil society, academia, private sector, and governments is that we now get solutions. We got ideas on how to combine also the different interventions needed, and then the need to integrate. So I think when we speak about integration into UHC, this is really about financial protection. It's really about to change the current picture of NCD driven by poverty and driving poverty. And we need to be more specific, in my view. And of course, to be more specific, you need to know the cost of the treatment, you need to know the data, the statistics, and you need to know what kind of healthcare workers that is needed, what kind of structures, and very, very importantly, the access to medicines. So I think ADG Professor Solomon said it as well. I think if we just look into what heads of states and government have suggested in the global NCD compact, they say we need to engage, we need to invest, we need to accelerate, we need to account, and we need to align. And that will be my second, because of course, there is also a route to go to look into comorbidities. I think we are doing that now quite successfully by working with countries and help countries to define the demand and also to define the comorbidities, actually, for example, between HIV and cervical cancer. And this is necessary because we hear ever so often from the international funding institutions that, well, we see the epidemiological shift, we see everything, but, you know, we haven't seen the demand expressed. So that is another place. And this is a very, very important place, both for government, but also for civil society. Just look into how strong civil society is when it comes to the priority setting in the Global Fund. So we need to have civil society speaking very loud about the comorbidity. So that's another piece of the integration. You were also asking about opportunities as we move towards the fourth high-level meeting on NCD. So I think first of all, I sincerely hope that the UHC high-level meeting will be granular enough so we can see also at least chronic diseases, or even better, NCDs mentioned in the resolution itself. I don't know yet if that will be happening. So please push for that. I think we need to be asked granular. But we also have Small Island Development meeting. And as you probably know, the Small Island was the one that brought the NCD agenda to the first political declaration. So again, this is an example where civil society and countries that really are able and willing to take the global leadership is leading the way. And the last is that we also need to have a second financing meeting. We need to be able to express ourselves as an NCD community in a more granular way than just saying we need more international funding or we need more domestic funding. We need to link this, for example, to the cost of the interventions or even to part of GMP. And I'm sure that we will hear more about that from my neighbor. So that was a little bit from me. Thank you.
Great, thank you very much. And there's a definite challenge there, isn't there? Yes, please, round of applause, round of applause. Looking at the political declaration being drafted at this very moment, you know, it's a challenge for all of us to make sure that it adequately addresses NCDs. And I'm sure a lot in this room are involved in these processes through the civil society engagement mechanism. So please be vocal, be active, and make sure that it gets the coverage that it deserves. So now turning to Stephen, you've done a lot of work actually looking at the financial implications of this, the impoverishment caused by NCDs and lack of financial protection. Can you perhaps sort of summarize the research that you've done recently, Stephen, and you know, what are the report's main recommendations to reduce this dreaded out-of-pocket expenditure, which is impoverishing millions of people?
Yeah, no, thanks, Rob. This is a piece of work that we at the George Institute did in partnership with the NCD Alliance. And it was a bit of a literature review, but we also had the privilege of access to 120 diaries of people living with NCDs across low middle income countries. And that was a really rich source of data of the lived experience that people had of NCDs, and focusing largely on the economic impact. So some very high level sort of findings, and these aren't necessarily our stats, these are stats that came from the review. There is, in terms of out-of-pocket costs, we're looking at about 44% of out-of-pocket costs for people for low and middle income countries. About 44% of healthcare is in out-of-pocket costs, compared to about 21% in high income countries. So that's a sort of a general statistic. But in terms of NCDs, what is interesting is that for a visit to a clinic, it costs about 2 times as much for an NCD than for an infectious disease episode, and that's just the clinic, and that's just the start of it, because with NCDs we often have the ongoing and sometimes lifetime costs associated with medications and some of the issues around impoverishment and non-adherence that Rob alluded to earlier. And these are typically not covered by insurance. So so this is a potentially an area that I'll just come to in a second when we talk about some of the possible policy recommendations that might emerge from this work. Finally, from the qualitative data from the diaries, what we found was that there were a wider range of coping strategies that people employed in order to deal with the burden of NCDs, including selling of assets, going into debt, borrowing within communities, and sometimes fairly ingenious ways in which they could raise enough credit to pay for their healthcare. But often these led to impacts that you could see would precede an intergenerational cycle in which the burden would then pass on to children. So in a sense, illness sort of leads to poverty, which in turn leads to more illness, and is something that is obviously part of the lived experience of a lot of people. But one of the things that often need to bear in mind that is one of the coping strategies that people do employ is not proceed with treatment. So they're non-adherent or they abandon treatment. And that's often a case in the very poorest income groups. What we often see is that the people who are incurring catastrophic costs are actually the people who have the confidence to proceed with treatment and ability to, in some ways, pay for those costs. So in some sense, you can argue that the non-adherence and abandonment of treatment is a hidden problem associated with the out-of-pocket costs of care, and it's often not picked up in the sort of studies that we do in this area. Just finally, I just want to sort of touch on one possible area where we can sort of think about policy recommendation, and it focuses on the area around universal health coverage. What we found is that often people experience catastrophic costs, high impoverishment, even when they have insurance coverage. And that goes back to the point that we talked about earlier, where not everything is covered, and one area in particular are the ongoing costs of medications, and that can have a major effect on households. And I want to sort of then sort of touch on the point that Rob raised around the political economy, because with these out-of-pocket costs and acting as a barrier to ongoing treatment of medications, we know a lot of these medications, particularly for cardiovascular disease, are highly cost effective. So you would think as a win-win situation from a political economy point of view, that coverage for these sorts of treatments would be a political as well as an economic a win for government. But I'd be interested in hearing your thoughts later. Thank you.
Great, fantastic. And of course, worth noting that, this issue of people not adhering to treatment, being impoverished, happens at all income levels. I mean, it's one of the famous stories about sort of the failings of the US health system, sort of people with diabetes not getting their insulin and sort of not getting their full treatment. So I think really emphasizes this point about the importance that these medicines are publicly financed rather than privately financed. So Ruchika, if I can turn to you now and ask you, what are the challenges that you have experienced in developing partnerships to deliver people-centered integrated health services? And secondly, what would be your advice to others who are considering supporting NCD prevention and care services as part of support for UHC?
Well, I would say NCDs are complicated, so you have to have a lot of patience for problem solving to start with. I think so. We've been developing sort of tech-enabled community-based solutions to manage and treat NCDs, and it's really been a journey. I would say there is no one solution that works in every setting, but the key thing to think about it is, what's the end goal that we're trying to accomplish, right? It's like at the end of the day, the patient has to get better. I think one of the defining things about NCDs is that if you can detect hypertension or diabetes or cancer earlier, the cost of treating that and the lived experience of the patient is fundamentally different than if it happens once the patient is at a point where they have had stroke or renal failure. So how do you incorporate that and those improved outcomes for patients as your sort of North Star is important. To do that, that requires thinking outside the box, starting with the patient. So explaining to the patient why this is important, why adherence is important. And that's not us. That has to be the frontline health worker. That has to be every person in the local facility that also needs to understand and be able to communicate that. And that when they see the deterioration, almost that they catch it before it becomes really acute. So in that sense, forming those partnerships or developing solutions requires engaging everyone. It starts with engaging patients, engaging every level facility, every staff, the HR, the HRIO, the health systems person, the administrator, the nurse, and then also all of the physician society groups, the civil society groups, and at a national level policy. So it goes to all of that. The challenge with all of that is it requires patience. So, but it's worth the time and the effort. And that's what I would say for the second part of the question that you asked, Rob. Like, any advice I would have is that I think if we really take the time up front to look at this very sort of complex ecosystem of stakeholders that each have a role to play to improve outcomes for the patient and bring them on board from the beginning, it's worth the time, and really orient around improving the outcome and the lived experience of the patient as the North Star. That's important. It's not just about reporting or, just medicine availability, because patients are not taking them or don't understand that. So really, how much better are patients doing? And we have the tools to be able to do that. We have solutions to do that. So those are the two things I would say. Take the time to engage all of the stakeholders and orient around improved life experience for a patient as the North Star.
Lovely. Thank you very much. Thank you very much indeed. And I think this is going to lead on very nicely to some of the discussions we're going to have in the second panel about how do we engage everyone, in these issues. And I should say that my panel has been absolutely exemplary, because I've got on my schedule here that we should have 10 minutes for Q&A. And amazingly, we do have 10 minutes for Q&A. So this is a first, I would suggest, for this room. So please, maybe you'll be able to take 3 questions. And so it really is a case of first hands I see, I'm going to pick them. So don't be shy. So we're going to go 1, 2, and right at the back. That's handy. We've only got 3 questions, so that's perfect. So roving mic coming round. And if you can bear standing up and saying who you are. I think the lady over there was actually the first one. Sorry, if you just pass it over into the middle. Yeah, that's it.
Sharbani Chakraborty from Technical University of Munich, and I wanted to bring the focus on prevention, because patients are not passive people. Nobody's passive. And when you look at prevention, whether it's obesity prevention, communities and people face a lot of barriers. And so how do we address that as well as part of universal health coverage? Over.
Tell you what we should do, I'm going to take all 3, and then that gives the panelists a bit of an opportunity to pick the one that they like. I'm seeing extra hands going up now, which is what I hadn't planned, but yes, please. And then the gentleman at the back. And then I'm afraid that's it.
Howard Catton from the International Council of Nurses. I wanted to pick up on Rashika's comments. The conversation up until we got to Rashika was about affordability in relation to medications, but you brought out really very importantly issues about preventions, adherence, managing deterioration, stability, questions people might have about their conditions, and how hugely, hugely important the healthcare workforce was to ensuring that we know that our healthcare workers, we know we've got huge global shortages, we've got people under massive pressure. We know that actually UHC is one of its greatest inhibitors. There just aren't enough healthcare workers. So what is the role do you see from the Alliance for arguing, for advocating, for making the case for investment in the healthcare workforce?
Excellent, thank you. And right at the back was the last one.
Thank you. I'm Bruno Hellman. I wear many hats, but here speaking on behalf of NCD Alliance, Our Views, Our Voices advisory group. I don't want to make a question, just to highlight something on the importance of the usage of language. We know that we are all here allies and we advocate for the same thing, but it's really important that we translate into language the mindset and mood and stop using the word patient, because we don't want to treat people living with NCDs, as my previous colleague mentioned, as they were passive. We want them to be to have an active role. So we need to start taking for granted the position that we believe we stand for, and understand that we are part of the conversation and we shouldn't be treated as so. Thank you.
Great, very good. And that's obviously a popular sponsor in the room. Thank you very much indeed for bringing up that point there. So if I turn it over to the panel now, so if you'd like to sort of pick which one you'd like to address, thinking about prevention and workforce. So first with the microphone, Ben, would you like to kick off?
So I would like to pick up the prevention side, and at the same time also a comment to Rishika, because I think the worst thing we can say to policy makers is that NCD is difficult and complex. We have to make it much more simple. And I think one of the ways it's not simple, I agree, it's not simple, but one of the way we can make it possible for governments to really understand how to deal with NCDs is to focus on prevention. It's obvious that that cannot be diminished at all. So of course, sometimes when we are asked to talk about universal health coverage and essential benefit packages, prevention seems to be sort of drifting away from the picture. I think we need to constantly remind that the most important thing is to prevent towards these diseases. But I also want to introduce one more thing. I know it's maybe not polite, but I think we also need to be much more vocal also as professionals. It's actually about huge inequities. I have started to talk about immoral facts. And I'm so happy to tell you that now, just last week, India, for example, decided to have 75 million hypertensive patients on treatment before 2025. And this shows that it is possible. They will be able to think through that, and they will have to also include prevention, and they know that. So I just want to comment on the prevention side. And again, I think we need to be very clear. One thing is to integrate essential benefit packages and NCD into UHC. Another thing, but linked, is to integrate NCD into primary health care and the way we deliver the services and the prevention. And if we are unclear on this, I don't think we will make it to the mark. So I want to say that because I think it doesn't help. And we see that in many countries now, they do a huge exercise on essential benefit packages, but they forgot to look into their fiscal space or their opportunity cost, which is only so big. So if we sort of don't also challenge the governments to look into the priority setting, for example, diabetes and hypertension, which I see as immoral facts, because people don't get the treatment, they don't get the attention, I think we will not make it to the mark. I just had to say that. Thank you.
Excellent. Thank you very much indeed. Anyone else like to sort of pick up? Stephen?
Yeah, look, I'm sorry, I want to also go on the prevention point. And I mean, as an economist, I feel a little bit uncomfortable when we talk about prevention over treatment, NCDs over infectious diseases, so forth, because there are obviously good buys within infectious diseases as well as bad buys, likewise NCDs, likewise prevention. And I think the importance is being able to establish the case for investment for whatever area of prevention you're interested in. And most of the programs that we're talking about, particularly in NCD prevention, represent some of the best buys in the health sector. And I think if we present the argument not just in terms of privileging one area over another, but by arguing the case in terms of this represents, a good investment, a good buy, I think it's a much easier way of winning over the argument. And I also have that sort of reservation in relation to the issue of equity. I often find that the appeal to equity, I mean, it would appeal to everybody in this room, but potentially only appeals to 50% of the population and 50% of the political sort of area. But it's very hard to argue against, the case that prevention may sort of pay for itself, or it may generate these sorts of economic benefits. I think those sorts of arguments tend to transcend across sectoral sort of interests.
Maybe I'll chime in on the healthcare workforce comment a little bit. I'm not sure I have a solution for that. I would just say it's absolutely paramount. They are at the front lines. And I would say it's not just physicians, but the community health workers, the nurses, the physician assistants, they're all part of it. Where in the little way we're trying to help is leveraging technology tools to make their life a little bit easier, make them more efficient so that every patient doesn't show up at a facility that doesn't need to show up at a facility facility and there's 300 people lined up and there's one doctor that's trying to take care of them. Can we use technology to triage those patients to say, hey, these patients are actually stable. They can be checked. Their blood pressure can be checked by a community health worker. And based on the risk stratification, we can decide who actually needs to see a specialist. And can we utilize those types of tools to manage the workload better, also keep more up to date and be able to provide more training and support for those frontline health workers, as well as physicians. But I think it's absolutely necessary. So anything we can do as an alliance to drive focus on that, we need to do.
Fabulous. Thank you very much indeed. I'm afraid we finished with questions for this panel, but you might be, I've noticed you at the back there, perhaps for the next one. So if I can have a huge round of applause for my panel, please. That's fantastic. And so maybe if I can ask you to leave the stage and for my second panel to join. So we'll do a bit of choreography now. So if I can have my second group of panelists up, please. And so that will be Mr. Stephen Ogweno, who is a member of Our Views, Our Voices Advisory Committee from Kenya. And also we should have Dr. Mohammed Abdulaziz, who is the head of the Division of Disease Control and Prevention, the Africa CDC. Next, we have Dr. Gina Agiostratidou, who is the Program Director, Type 1 Diabetes Program, Helmsley Charitable Trust. And then we have Professor Sheila Martins, who's the President of the World Stroke Organization, please. So welcome. And this second panel, I think we're going to build on the first panel, but now looking very, very importantly at this issue of engaging people, engaging communities, civil society organizations, because I think, you know, we've identified at the back there that we can't just be referred to people as patients. We're talking about people here and how vital it is if we're going to see NCDs covered properly. We need people-centered care. So if I can start with you, Stephen, please. We were chatting a bit earlier about the situation in Kenya and the organization that you're working for. So could you maybe sort of give us some indication of examples of how there's been meaningful involvement of youth and people living with NCDs, particularly in Kenya, where you're working, but also maybe looking globally. And what do you think are the challenges you have faced when seeking to engage in social accountability mechanisms for UHC?
Thank you very much for the question, and certainly building up on what has already been talked about. So myself, a person living with multiple non-communicable diseases. So the best example I could give to the question of what happens when young people like myself who are actually living with non-communicable diseases are engaged is part of the work that we did in Kenya between 2020 and 2022, just as the pandemic started and towards the point when it was ending. So we did a very exciting project in partnership with the NCD Alliance of Kenya, but also with the county government of Vihiga, where we young people who are living with non-communicable diseases, but also were professionals around the health sector, we collected ourselves through the organization that I lead, which is the Sterling Foundation, went into Vihiga County, which is a rural county in Kenya, which has high precedence for cardiovascular diseases. And when the conversation on COVID-19 came, the conversation on NCDs left. So immediately we started to speak about COVID-19. All of a sudden, the people who are living with non-communicable diseases like hypertension, a stroke, and the rest were not receiving services because a lot of the service was prioritized towards NCDs. So we went into the county, we volunteered for 18 months, and in our time there volunteering and working with the county government, we were able to have a lot of the conversations around what is the budget allocation for non-communicable diseases, and then how can we be able to increase that? So what we ended up finding out was that initially for that county government, the budgetary allocation for non-communicable diseases compared to the total health budget was just 0.8%. And this was supposed to be for both, prevention and also treatment approach. And so what we ended up doing is we brought young people together, formed the first technical working group in collaboration with fellows at the ministry, the County Ministry of Health, and the county itself. And we did a short paper on why it is important to be able to increase the budget. And we showed that if we're able to focus more on prevention for NCDs, and in this point, we're looking at cardiovascular health and diabetes in terms of increasing the screening services and sort of education for public health purposes, then it would be much better, because in the long term, we get to see a reduction in the cases that come for treatment, which already had a huge toll on the county governments. And so in the next year, which was in 2022, we ended up seeing some of our suggestions being implemented, which led to an increase in the budget from 0.8% of the total county budget to 3%. So clearly, you can see that, and this for us was also, it came as a very huge surprise that they actually listen, because most of the time they don't. So when young people are involved, and we were able to use this, and we really documented the process so well that others can, in the country and sort of similar contexts can duplicate, is when young people are involved, when people living with NCDs are involved, and when we work collaboratively with the various governments, then we are able to actually influence change. And when it comes to the second part of the question, which was on challenges that we face when we are looking at the social accountability mechanisms for UHC, we realize that various examples of social accountability. So it could be participation in the budgetary development, social audits, citizen scorecards, and etc. And what we've seen, and this is again going back to the Vihiga example that I used, is that one, there's a lot of challenge in giving a detailed, meaningful plan to track progress. So we talk about UHC and we talk about what we are going to do, but how exactly are we going to track it? How exactly can we, as people living with NCDs, as civil societies, as governments even, how can we be able to track that progress to say that at the end of this period of time, this was what was allocated for UHC, this is exactly what we were supposed to account for, and then we've accounted for it? Because what often ends up happening is that you have the funds to implement, and then you just report on what you did, as opposed to a predetermined set of objectives. So we see that as a challenge. And then we also see the other challenge being lack of access to information for participation. So you might want to participate in, the budgetary allocation process. You might want to participate in the accountability, following up with the various governments and entities. But for some reason, it has been designed in such a way that it's so hard to find this information. And when you find it, there's a lot of bureaucracy to get into the right rooms where this accountability and where you can be able to actually meaningfully engage. So as a challenge that is one of the other challenges that is, and I think it's by design. If I'm looking at the current health systems, I think it's done by design, and I think we need to do better in terms of making it much more easier to get into the rooms, to be able to contribute, and ultimately to be able to make change. So I'll leave it at that, and thank you very much.
Thank you very much indeed. Yes, a round of applause, please. And I think very, very important lessons about following the money. That is a really good way to indicate. People talk about political commitment for UHC and NCDs, but if they don't put any money in it, they're not serious. So I think congratulations to you for doing such an amazing job in actually seeing that money increase. So if I can turn to Mohammed now, please, to look at Africa CDC's experience. So what has been your experience of engaging civil society organizations and people with NCDs? I think you've just done a new strategy, haven't you, that's looked at this. And how does Africa's CDC plan to support its member states establish inclusive social accountability mechanisms within health system support to support progress towards UHC?
Yeah, thank you. Thank you so much. What we see across Africa, especially with people with lived experience on NCDs, and we did consult them when we were setting up the priority strategy to support our member state with, is that they feel left out. They're not involved in the decision making, and they've seen in the other areas like HIV where people were involved, and this, the progress that was made in that regard. If you take the 3 areas of universal health coverage, where you're talking about financing, health financing or coverage, or you're talking about service delivery, there is a plethora of discussion in that area that shows that people living with non-communicable diseases in Africa really feel that a lot needs to be done. If you take patients living with cancer, for instance, the cost sometimes of the medication, of the treatment, it could take 1 year's worth of their payment, and they in most cases have to use their little income and complemented by family members, which is not enough, leading to so many crises within the family. If you look at the government concentrate most of their intervention in non-communicable diseases in big hospitals, not minding the fact that 90% of the population cannot access those hospitals. So in some series, 90% of investment in health, in non-communicable disease, goes to those big hospitals, totally neglecting any form of preventive care. If we look, it was very telling when one of the people we interviewed looked at and said, Mohammed, we can see the experience in terms of the government will not be able to afford to treat all the NCDs if we do not focus on prevention. And I like the question somebody asked in the audience. So why don't the government focus more on trying to prevent? And the person talked about smoking. Smoking across the world dropped, and so has lung cancer. So these are things that we can do. And in terms of what Africa CDC is doing to control, to help with some of these things, that we realize we have to use the health system that is scalable, that is accessible, that even with the financing, it's relatively better in most of the African countries. And this is the use of community health workers. It's really important that we work to improve the efficiency and efficacy and the reach of community health workers, empower them using the different tools we have for stepping down the non-communicable disease service to the community, to the PHC. Also using them for prevention messages and the rest. So these are some of the things we're doing. Again, the prohibitive cost. Africa CDC have learned some lessons in the COVID-19, which involve that we will use some of the experience we've learned in NCDs, like pool procurement. Pool procurement can help bring down the cost. But for us, the solution on the continent is when some of these medication consumables can be produced locally at a rate that is affordable. That's the long-term solution that we are putting forward in Africa CDC. But for now, we also think if we can work with member states to procure some of these, their essential list and increase access, maybe we'll begin to see the light at the end of the tunnel. So two things, increase access to the medication used, and also the health system. You should use the one that is scalable, that is affordable, and which the government can scale up in the community to improve access. Finally, I think donors also need to rethink their ways of dealing with African government. And we were in Africa CDC, we are looking at that. We think we can make a lot of savings to use for NCDs if we avoid over verticalization of the different interventions on the continent. It's wasteful, it's inefficient, and it prevents the government from scaling up service. If you're paying a community health worker beyond what the government can afford for HIV, for TB, then no community health worker will agree to do for NCDs, where in most cases, the government that we scale up in this area. So these are some of the things we're looking at to see how we can really improve access. Thank you.
Great, thank you very much. Round of applause, please. And I think expectations are high, the extremely important role the Africa CDC has got in helping develop health systems, and also holding donors to account to improve their performance in integrating. So thank you very much indeed for that. Now, if I can sort of turn to you now, please, sort of Gina, to hear about the role of the Helmsley Charitable Trust, and perhaps you can sort of give us examples of the work that you've been doing, particularly with people living with diabetes, and also sort of thinking, what is your view of the role of philanthropic organizations have in the global quest to achieve UHC, and in particular coverage of NCD services?
Thank you very much for inviting me. NCD Alliance has been such an amazing partner to our program. So I would like to start saying that basically in Helmsley, our goal is to foster access for everyone. And especially in the type 1 diabetes program, Global Access Portfolio, we address the immediate and urgent need of those with type 1 diabetes today, while we pave the pathway for more sustainable and integrated health systems. But this goal cannot become true without listening to people with lived experiences with type 1 diabetes. So the Helmsley Trust is about 13 years old, and 8 years ago we started our journey in the global global access. And after we gave grants for healthcare strengthening in a couple of countries, we went to Rwanda. And there we had the opportunity to meet with the Diabetes Association, and we were really struck by the efforts that they are doing for people with type 1 diabetes, providing insulin, providing other diabetes supplies, creating training programs with people with type 1 diabetes. So we talked to the leadership and we said, what do you need? What is the something that you need? And we were quite surprised. They asked us if we can provide funds to buy a car to basically bring people with type 1 diabetes to their appointments or to training society or to training sessions. Then a couple of months after, I had the opportunity to talk with a mother who had a young child with type 1 diabetes, and she moved from UK to Panama. And she had difficulties actually to have access to insulin, and she wanted a couple of thousands of dollars just to bring together other parents and to advocate for insulin access. So we went back to the program and we had a discussion. What do we do? How do we really identify and give voices to these very small organizations to advocate for what they care about? So after a bit of time, it was a bit of challenge to find the right organization. We worked with Panorama Global to launch the T1D Community Fund. This fund supports community-based organizations working to close care gaps in low and middle-income countries, empowering communities and build networks in country partners to inform decision-making, like our organization. So we were excited to receive about 60 applications. We initially have found 16 of them, and this is the beginning. We believe that giving the voice to people with people with lived experiences is so important. Helmsley's work with NCD Alliance is another testament that Helmsley really values the voice of people with type 1 diabetes and other NCDs. We have joined the cause of NCD Alliance by supporting NCD Alliance chapters in Malawi, Rwanda, Tanzania, and Mexico, and the Regional African NCD Network, where we help mobilizing communities and sparing local involvement in building stronger systems of NCD care. We also support the NCD Alliance's Our Views and Voices initiative, because we believe that amplified voices of people with lived experiences, building solidarity across the NCD community while combating stigma and discrimination. Now about the government, about how government and UHC. You said yesterday, and we were so happy to hear that actually, that universal health coverage can be realized and implemented only if governments lead it and champion it. We totally agree with that. And as a philanthropy, we're always questioning what is our role. We believe that basically we need to fund projects that build on government's priorities, demonstrating that T1D and other chronic NCDs care is feasible. We believe that actually philanthropy can play a critical role in bringing new, innovative partners into neglected issues like NCDs. This paves the way for testing implementation models and establishing evidence of cost effectiveness so governments can scale proven solutions. An example again, as you know, in resource-limited settings, chronic care services are often available only in the major cities, putting life-saving support out of reach for thousands of people, thousand lives living in rural areas. The PEN Plus model fills this gap, bringing clinical chronic care to district hospitals and training nurses to provide quality NCD care. PEN Plus is present in more than 10 countries. There are in different levels of implementation. I'll bring up two examples that we saw how basically philanthropic supported projects, PEN Plus, NCD Alliance in Malawi, Partners in Health, they worked very closely actually with the Ministry of Health in Malawi to build trust, share information, and coordinate NCD activities across disease silos. Another example is Rwanda. In Rwanda, PEN Plus started many years ago, and today PEN Plus is implemented nationally by the government. And what we had there, again, we had philanthropic support and the role actually of community-based organizations. I would like to close by saying that in order for solutions to be reality and for universal health coverage to be reality, we need all the major players. We need government, we need philanthropy, we need community-based organization, we need the voices of people with lived experiences. Thank you.
Fantastic. It's a wonderful summary. And that crucial partnership of all those stakeholders, absolutely essential to ensure that you get the public financing of the state, making sure that everyone gets coverage. So finally, if I can turn to Sheila, we're still doing fairly well on time, and really sort of looking at the PAHO region where you're based, and just wondering if you can sort of give us good examples of NCD-focused civil society organizations pushing the frontiers of NCD coverage in your region, and also perhaps the important roles of coordination of the NGO networks, and maybe the role of data as well in achieving that coordination.
Perfect. Thank you for the invitation. It's a pleasure to be here to talk about this. Well, the whole of civil society is important, and as experts, our society, we have several experts, we have societies, we have patient societies inside, and we can build the knowledge, we can create the guidelines, and this is not enough, we know, and we can work together with health managers because we know how to implement. I think this is very important, and because of this, we start to work in the region, first in Brazil, on that time to create stroke services, because we didn't have in Brazil, we have prevention, but not acute stroke care. On that time, we start to work individually as stroke experts, convince the health manager in the city or in the hospital to organize stroke care. We start collecting data in several countries in Brazil, working on this to show the results. And we had the opportunity to show this work of 35 hospitals to the Ministry of Health, showing that organizing acute stroke care decrease mortality, decrease disability, decrease the length of hospital stay, decrease the IC intensive care unit beds needs, and we show that is cost effective in public health system. So with this, Ministry of Health invite us to work with them, to recognize the situation in the country, and to start a national plan for stroke that was published. And with this, we decrease the mortality and disability for stroke in Brazil. And these stroke centers are working in the region to create the line of care, training the pre-hospital, the primary care units for prevention and recognition of stroke, working with stroke support organization for patients, for aware the population about stroke. So really works very well. And with this, we go to other countries in the region, invite Minister of Health of other countries and specialists to discuss the gaps in the region, the best models, the possible solution, and we create a plan for the region that since 2018 we are following, and the governments are following. In 2020, through World Stroke Organization, we create the Global Stroke Alliance, really putting together all initiatives for implementation, experts, researchers, health managers, health ministers, patients, and industry, discussing the best initiatives to implement stroke care, not only acute prevention, acute care and rehabilitation, and works very well. Last year, we had 17 countries from Latin America and Caribbean region and 7 ministries of health for 3 days discussing with us the plans for the country. So really works very well. And the data is fundamental, collected data to show the results with this. While we are working in several ways, we are working in prevention, hard implementing of HEARTS program in the region to decrease the burden, to start primary prevention and secondary prevention with a strong educational part for the health professionals in primary care. And now we are working in a global coalition for circulatory health together with World Heart Federation, World Stroke Organization, societies for diabetes, for kidney disease, because we have the first one killer, and in the world, 20 million people each year dying for this disease. And we have different similar disease in different parts of our body. So we are working together, and we launch today a position paper of this coalition, why integration of circulatory disease interventions are important in primary care. And we include effective and cost-effective strategies for prevention with focus in hypertension, diabetes, cardiovascular disease detection, and stroke and kidney disease, including medications for primary and secondary prevention. So we include 3 asks for the policymakers to increase the universal health coverage to include circulatory disease by 2030 to decrease the huge burden, to prioritize the primary health care in the budget, in the national budgets, and also to prioritize cost effectiveness strategies for this disease. And we, as experts, are available to help to tailor the programs and to implement too. Thank you.
Great, fantastic. Thank you very, very much indeed. And I think very clear the way you're setting out 3 clear asks. And I think that's absolutely essential when talking to busy politicians, that you've got a nice, concise story for them to understand. We do indeed have a bit more time for questions. I can take 3, one at the front, the lady there, and the gentleman over there. 1, 2, 3.
Hello, everyone, and thank you for some interesting insights. My name is Abdul Karim Haraku. I'm a medical doctor from Denmark. My question is primarily to Dr. Mohammed and Dr. Gina. The 5x5x NCDs, due to the WHO definition, states that the last part is also air pollution and mental health. And you talked a lot about a lot of interesting stuff, but none of that was mentioned actually. So I would like to hear, is that a focus that you have? If yes, how so?
Thank you. And so I'll take all 3 again. So there was, yes, please. Yeah. Yeah, sure.
Thank you so much. My question, and thank you, first of all, Stephen, for sharing your valuable experience living with a chronic disease. We need more people on panels sharing their experience. I just want to say one comment, that living with a chronic disease is very hard. It's lonely, it's exhausting. And I want to, like everybody in this room, should understand we need to be an ally and not an obstacle. Like that's the message we need to understand, how we can make things easier for people living with, not just calling them on panels and sit and just listening to their story. We just don't want to be left as a story. We want real committed action. And for that matter, we as organizations today need to be answerable on how are we defining engagement? How are we ensuring that we are not leaving people's voices just to be a story? We need to define engagement because we need to shift the lens from voluntary work of sharing stories to meaningful action, integrating people living with in a real action world. That we are the solution ultimately. And I'm sharing this because I work, so I didn't introduce myself. I'm Apurva Gomber from the NCDI Poverty Commission, and I work with Gina on the Pen Plus work, which she really shared about. But also I'm a person living with type 1 diabetes. And while working with a lot of people in the advocacy space, I've realized a lot of them share this common narrative. I just felt like my story was used. I didn't see an action. Like policymakers just keep the people living with NCDs on their table just to listen their stories. What do we need? What do we want? But they don't involve them in the real action. So when we define engagement of like to ensure engaging people, how are we making sure we're accountable? How are we shifting the lens to real committed action for great solutions? So
great.
That's my question.
Thank you very much. Extremely powerful. And really, I think it'd be wonderful if more people with chronic diseases became policymakers themselves, you know, so go into politics and really sort of fight your corner. So that's now I've got flurry of hands now. Yeah, the gentleman there, and I did point to the lady there as well. So 4th, yep.
Thanks to all the speakers for the great panel. I'm Bassem, I'm a medical doctor, and now I'm a founder of a startup, Health Tech. And we offer virtual team-based care. all this is just to ask the question. It is to Sheila. So in your work, did you touch on care pathways, like how, like we find that a lot of work is on the bigger picture, or the notion of integrating primary, secondary, and tertiary care, but at the end, the patient perceived the journey as one. And how were you able to put the patient journey, workflow of doctors and other healthcare workers together in an integrated pathway for stroke? And how can you transport this experience to other disease areas? Thanks.
And finally, yes, you got the microphone.
Thank you very much. Is it on? Yeah, okay, thank you very much. Sarah Collinson from Sight Savers and also the International Disability and Development Consortium. I just was thinking about some of the comments about the accessibility of services. We know that NCDs, people who live with chronic conditions resulting from NCDs, it's one of the major causes of disability globally. And so I wanted to highlight the WHO has recently published a global report on health equity for persons with disabilities, which identifies multiple health system barriers for those living with long-term conditions and disabilities associated with NCDs, as well as other causes of disability. And that might include things like transport barriers, as we've just been hearing about. And so it seems to me important to link up these agendas, actually. The WHO will soon be bringing out a guide for action following up on the global report, which will include a lot of very practical advice that governments should take, because I imagine that the barriers, once someone has a disability from a non-communicable disease, they then face those barriers that then contributes to comorbidities, and they are among that huge part of the population that experiences barriers as a result of those long-term conditions. So I think it's really important to join the dots between these agendas. Thank you.
Yep, excellent points. You know, they're very much the point about health in all policies being essential. So panelists, if you can be nice and concise, we're sort of straying dangerously into extra time. So who's going to deal with which questions?
Seeing that everybody's looking this way, I probably might start. Yeah, so I won't address any questions in particular, but I'll sort of address the comment on lived experiences, just to really reiterate and really to draw attention to why it is important that people living with non-communicable diseases are actually meaningfully engaged. So not just placed on panels just to share their stories and get used and ultimately not transform into change. And this is just true sort of because I know there's a lot of government representation here and a lot of the organizations that make the work go or the work move on various points in non-communicable diseases. This is just sort of a call and a reminder just to let you know that us as people living with non-communicable diseases, we are experts, not only in the disease itself, but also in how we can be able to, you know, create solutions to it, but also technically experts as well, that we have the education and the capabilities to actually meaningfully engage and contribute when these programs and interventions are developed. Also, just to remind us that we're also very knowledgeable and we are in touch with the actual realities on the ground. So whilst a lot of the conversation is usually on high level engagement, we actually are the experts in what we experience on the ground, and we represent a whole lot of people with these experiences. So our opinions certainly should be taken into account when these projects are happening. And then lastly, and coming back to the original submission that I made, is that when people living with non-communicable diseases, when we are actually meaningfully involved, we deliver, and the results create huge impact on the ground, which leads me to leave with one question to the audience is, what are you going to be doing today to engage more people living with non-communicable diseases in your programs, actions, and policies? Thank you.
Thank you so much to the audience for the wonderful questions. Let me address the issue of mental health, because we, like you notice, we totally omitted that. Well, maybe we lumped it together with non-communicable diseases. As a consultant psychiatrist, I am a consultant psychiatrist. When I was practicing in Nigeria, I realized that I was seeing less than 3% of people who required my care, because the cost of getting to me was way too high for most of the population. That's one of the reasons why I left clinical medicine, clinical practice, to come into public health, because I felt this required a public health solution. And part of what we are doing, and also answering the question on things that need to be done concretely to make a difference. Part of what we're doing is to see in Africa CDC, the different solutions that have worked. I piloted MH-gap delivery of services at the community in 2 states in Nigeria. The HUPEN that is she talked about in Tanzania, we are looking at that. And concretely, what we want to do is to strengthen the member states of African Union to be able to look at this program and scale it up. And I totally agree with you. We need governments to do this. It's not, we need government ownership. We need government acceptability and their ability to look at this and scale all those programs that brings mental health, non-communicable diseases to the PHC. Specifically, also when we look at the what Africa CDC is doing to ensure a change, and that is why all the actions we are taking now in terms of the priority to support member states are the ones that we can measure tangibles. It's not just to say we'll do this, we'll do that, we'll do that. No. To be able to do that, I repeat, we need to work with the people with lived experience, the civil society, to put pressure on the government to increase funding for non-communicable diseases as a whole. One of the things the challenges we noticed in Africa CDC is the lack of real leadership. When you come to this kind of meeting, except dedicated ones, you will not see mental health or NCDs speaking in the audience on the panelists. So we want to really using the leadership program at the Africa CDC to help our member states workforce to have leaders in public health that can sit in panels and talk about non-communicable disease, injuries, and mental health as a way forward. Thank you.
Thank you very much. Gina, Sheila, you want to?
Thank you. Well, I really believe that you need to organize the full line of care, since the patient awareness about the disease, the prevention and acute signs, pre-hospital, acute care in the hospital, etiological investigation and early rehabilitation, and a plan to discharge this patient for secondary prevention and to reintegrate in the society. So we need to organize everything. We started in the hospital because was the opportunity I had. And with the hospital, when we create a national plan for stroke, we put that the region should be responsible, the health secretary, to organize the complete line of care, including everything. So it was very good because really everybody works to implement everything. But it was not enough. We create our national policy in Brazil 2012, and the number of strokes are not decreasing. And when I saw the HEARTS program from WHO, I loved it because this is what I want. Yeah, because we had the opportunity not to teach how to treat hypertension, but how to implement a program to detect early treatment and to achieve goals, to monitor and to work as a group, to work with a multidisciplinary team. So we start to work with the HEARTS program. As a neurologist, I of course, I didn't do alone. I create a committee with several experts and family doctors and patients and nurses to discuss the plan, to start the implementation in a pilot using these students to evaluate a tool for monitoring. And when we train all doctors for my region, I was, oh my goodness, a neurologist training the family doctors was amazing because they love the possibility to have a simple tool, a simple protocol to make the decisions. So really, I'm proud of it. And we are working to improve now rehabilitation, that is other gaps. So I think we as doctors can work on this and help to develop the systems in each part of the system you work, and the patients can help us to advocacy, to aware the population, and to ask for the rights to have a better care.
Thank you very much indeed, Monica. And Gina, do you want to make another point too?
A very short comment. We don't fund any mental health, but we always think about how NCDs can be related, how care of NCDs can create mental health issues. The only thing I wanted to say, I've been here in 2 days. I've heard from many different wonderful people, and what makes me think is that at the end, we are all people who are, depending on where we're born, we experience NCDs, infectious diseases, mental issues, climate change. And I think we have to say that the universal health coverage, it is the solution. Although I represent type 1 diabetes, I thought I really want to hear about how people think beyond diseases, but think about the person perspective.
Thank you very much indeed, Jean. And maybe just one final reflection from me, actually, because I was thinking this morning as I was preparing for today, I was listening to a radio interview, and it was with the UK's leader of the opposition talking about their sort of strategy for the next election. And needless to say, big discussions about our National Health Service, which is 75 years old this year, the same as WHO. And you can definitely see that the strategy of the Labour opposition is to really challenge the existing government on access to health services. And all the discourse was really around access to NCD services. It was all about surgical waiting lists, mental health services, and you could very much see that the Labour Party are thinking this could be a strategy to win the next election. And I think it just really reflects just how people really care about these things. And really my advice is politicize it as much as possible. And if you want to get your NCDs covered, really get involved in politics. So thank you very much indeed. And I hand back over now to Monica to wrap up. Thank you. And thank you so much from a panel. Please, round of applause from a panel.
With just over 3 months to go until the UN high-level meeting in September, and the zero draft of the corresponding political declaration in circulation, the clock is ticking. To ensure heads of state use this opportunity to move the agenda forward. Today, we heard views from experts, colleagues, friends, who have reminded us of the unique opportunities and challenges that NCDs bring for the progressive realization of UHC. And there are 4 key asks under the headings of invest, accelerate, align, and engage. And we had excellent views expressed by our speakers. And I'm quickly going to just mention these under these 4 asks. So we had invest, very clearly laid out by Dr. Mickelson, accelerate as per the Georgia experience, increasing funding exponentially, and aligning because of Dr. Abdulaziz's reminder that over-verticalization is wasteful inefficient, and prevents the government from scaling up services. Engage, we heard from Dr. Salomon, who's reminded us achieving our goals is impossible without placing the voices of those with lived experience at the heart of decision-making processes. By learning from one another, we can accelerate the path towards equitable health systems. So with this, I would like to just conclude saying NCDs are a global issue, health security issue, a development issue, and equity issue. We can accelerate UHC implementation by including quality NCD prevention and care services in our country's UHC health benefit packages. It's in this spirit, what you would have been seeing around the posters, that campaigns of NCD Alliance Global Week for Action on NCDs are conducted. They're running from 14 to 21st September and are important to mobilize the NCD community and make the high-level meeting a political tipping point. Thank you for your attention and your ongoing support for people living with NCDs. Bruno, we will use the right terminologies. Thank you for reiterating that. In particular, I would like to thank our co-host for this event, Helmsley Charitable Trust, and extend our gratitude to our esteemed panelist and moderator, Dr. Yates, for joining us today. We are now going to close the session, but just a small video listening to a call to action from across the NCD Alliance network. And after this video, I would request you all to please join us outside for the reception to continue these interesting and engaging discussions. Thank you.
In the run-up towards the high-level meeting on universal health coverage, we call on the heads of state and government to lead the progressive realization of UHC to meet the needs of people living with NCDs.
Hacemos un llamado a los líderes mundiales para que se comprometan a invertir y acelerar la incorporación de servicios esenciales de prevención y atención de las enfermedades no transmisibles a lo largo de la continuidad de la atención en los paquetes nacionales de beneficios de la salud en la cobertura universal de salud, en tiempos de paz y frente a emergencias de salud y crisis humanitarias.
We call governments to align development and global health priorities to achieve UHC.
Countries need to engage people living with NCDs to keep UHC people-centered by formalizing opportunities for meaningful involvement of civil society in UHC governance and decision-making roles.
NCDs are a global issue, a health security issue, a developmental issue. NCDs are an equity issue.
Recording